Hello, my name's Dr. Rajani and I'm one of the consultant cardiologists at Guy's and St Thomas's NHS Foundation Trust in London, and I'm going to be your host for this webinar today. In this webinar, we're going to be looking at diffusing the challenges of complex structural heart interventions using advanced imaging. And these are my conflicts of interest to declare. I work as part of a large transcatheter mitral team across King's Health Partners, and King's Health Partners is incorporated by King's College London, King's College Hospital and also Guy's and St Thomas's Hospitals. We have a large transcatheter mitral team across King's Health Partners, and this includes interventional cardiologists, cardiac imagers, cardiac surgeons, also collaborations with industry, and also our university division, which has a specific expertise in computational engineering and also bioengineering. So the learning objectives for today is going to be to talk about how we plan for complex transcatheter mitral valve interventions using the whole spectrum advanced imaging modalities that we have at our disposal. This will include cardiac CT, transthoracic echocardiography, transesophageal echocardiography, computational engineering, finite element modelling in computational fluid dynamics, along with a specific emphasis on fusion imaging techniques. And that will be fusion imaging techniques with CT fluorofusion and also CT echo fusion. This will then be followed by two very interesting cases that we have for you today. The first case will be of simultaneous transcatheter double valve treatment of severe calcific aortic and mitral valve stenosis secondary to prior mediastinal radiation. And the second case will be willful anterior caudal repositioning to facilitate mitral valve-in-valve implantation. And both of these cases highlight and showcase some of the imaging modalities that we use at King's Health Partners to plan for some of these procedures. This will then be followed by a wrap-up and some conclusions. The way this webinar is structured is that we will have various breaks during the course of this webinar where there will be an opportunity to ask some live questions, and I will do my best to answer those questions for you at the appropriate time. So to start off with, let's consider transcatheter mitral valve replacement. We know that when we do transcatheter aortic valve replacement, that cardiac CT and echocardiography are the core fundamental imaging techniques to plan and ensure that these procedures go well. However, when we're looking at the mitral valve, this is a far more complex structure than the aortic valve. And we need to consider not only the anatomy of the mitral valve, but also the physiology. Every component of the mitral valve and its apparatus needs to be considered when planning for these procedures. This encompasses the left atrium, including the left atrial appendage, the pulmonary veins, the mitral valve annulus, the left ventricular outflow tract, the papillary muscles, the chordae tendineae, and also the geometrical architecture of the left ventricle. We also need a specific consideration to the physiology of the mitral valve. The mitral valve annulus itself deforms during systole and diastole. We need to factor in the degree of mitral valve regurgitation, the mechanism of the mitral valve regurgitation, whether it is primary or secondary, and we also need to try and encompass a degree of predicting what the outcomes will be once the preload and the afterload conditions of the left ventricle are altered. What complicates transcatheter mitral valve planning is also the huge different array of devices that are currently available on market, which involves a patient-specific and also a device-specific approach to planning. Now, the thing we need to know about the mitral valve annulus is that in essence it can be described as being a hyperbolic paraboloid. So in other words, the area will decrease by approximately 24% during systole, during ellipticization. Now this confers specific geometrical properties that need to be accounted for when we're performing imaging planning, either with echocardiography or multi-phase ECG-gated cardiac CT. There are recommended techniques for planning for transcatheter mitral valve intervention, and the most commonly employed is that published by Blanca et al. In JACC 2015. Now this essentially describes the mitral valve annulus as a D-shaped annulus. And you can see here on the left-hand image that we can take a number of different measurements of the mitral valve annulus, from the lateral to medial trigone, the mitral valve annulus area, the mitral valve annulus perimeter, the septal to lateral distance, and also the intercommissural distance. And all of these measurements should be taken of the mitral valve annulus, ideally at each phase of the cardiac cycle. The reason we often recommend taking these measurements at each phase of the cardiac cycle is that the area of the mitral valve annulus will vary, and in some individuals it will be greater in systole, and in some individuals it will be greater in diastole, and this can be dependent on the mechanism of the mitral valve regurgitation in the first place. As well as taking specific measurements of the mitral valve annulus, we also need to incorporate various different factors that may complicate a transcatheter mitral valve implantation. And the two main areas of concern are device dislodgement and also the introduction of an outflow tract gradient. And we'll come on to this a little bit later on the next couple of slides. Now, in terms of the steps in locating the mitral valve annulus on cardiac CT, this is relatively a simple approach, and all it requires is the incorporation of multiplanar reformatted imaging. We place our crosshairs at the mitral valve annulus in the 4-chamber view and also in the 2-chamber view. Now, by placing our crosshairs at the base of the anterior and posterior mitral valve leaflets in both the 4-chamber and the 2-chamber views, we can bring out the D-shaped annulus from which all of our measurements can be taken. Here you can see that I've used a polygon tool to trace around the mitral valve annulus to give us the annulus area, the annulus perimeter, the intercommissural distance, and also the septal to lateral diameters. Now, as I've mentioned, the main concern with transcatheter mitral valve replacement therapies is the introduction of left ventricular outflow tract gradients. Once a transcatheter mitral valve is implanted in the mitral valve annulus position, we can get displacement of the anterior mitral valve leaflet towards the basal septum. And this introduces a new left ventricular outflow tract, which is also called the neo-left ventricular outflow tract. Now, if you have a small left ventricle, an acute aortomitral angulation, you can get a significant left ventricular outflow tract obstruction, which may be problematic post-deployment of the transcatheter mitral valve. A number of different factors have been proposed as contributing to a significant outflow tract gradient, and these are illustrated on this slide. These include device protrusion, device flaring, an acute aortomitral angle, and also the presence of a basal septal bulge. This slide demonstrates how you measure aortomitral angulation. Now, the aortomitral angulation is basically taken from the base of the mitral valve annulus, and a line is drawn at the neo-left ventricular outflow tract. From this, you can measure a specific angle. It is important to make sure that this angle is measured at a number of different cardiac phases, as this may vary depending on regional wall motion abnormalities and also the specific geometry of the left ventricle. When planning for transcatheter mitral valve interventions, it's also important to evaluate all of the other structures that may be of relevance. In this slide, we can see that I'm measuring the distance from the mitral valve annulus to the height of the left atrial appendage and also the height of the pulmonary vein. We have to make sure that the left atrium is of sufficient size to accommodate a transcatheter mitral valve device, and we can also see here some of the mitral valve annulus specific morphological features. You can appreciate that there's a little bit of calcification at the posterior mitral valve annulus. There is also myocardial thinning at the mid to apical inferior segments. We also need to evaluate the left ventricular size, and this can be done using standard techniques and computer segmentation from standard cardiac CT datasets. We're looking at the apical 4-chamber view, the 2-chamber view. You can see that there is myocardial thinning with an aneurysm at the basal inferior wall in keeping with the prior inferior myocardial infarction. We've got our 3-chamber equivalent view with the outflow tract being visualized and also the aortic valve. And here we've got some short axis views as well. Once again, you can see some calcification at the annulus and also some thinning over the septum. On the right-hand side, you can actually see the left ventricular outflow tract area, which will be a point of consideration, which we'll review on the subsequent slides. It's also important to appreciate the distance from the heights of the papillary muscles to the mitral valve annulus. And you can see here that by placing the crosshairs across the tips of the papillary muscles, we can bring out the papillary muscles in full in the 2-chamber view and measure the distance from their tips to the mitral valve annulus. It's important that there is enough space in the left ventricle which is unimpinged by papillary muscles or cords to accommodate a transcatheter mitral device. A further consideration in transcatheter mitral valve planning is also to consider the access. At present, until we await for transeptal devices to be employed, often the approach is using a transapical approach. So we will often acquire a non-contrast ECG-gated cardiac CT to get an appreciation of the thoracic anatomy. Here we can clearly see the rib spaces, and also their relationship to the apex of the left ventricle to help guide the optimal puncture point to gain access to the left ventricle and also the mitral valve annulus. This is just an example of a CT scan that was acquired post a Medtronic Intrepid valve being implanted. We can actually see that although we would anticipate for there to be anterior mitral valve leaflet displacement, this is not always the case, and this is due to tethering from the papillary muscles and the cords that are inserted onto the mitral valve. We can see in this particular example that this specific device is exceptional because it allows for geometrical conformity to the mitral valve annulus during systole and also diastole, and there's no significant left ventricular outflow tract obstruction and no flaring of the device. Another consideration with transcatheter mitral valve therapies is also whether or not these devices are prone to develop thrombus on their underside, and for one of these reasons it's important that the ejection fraction remains not severely impaired at the time of deployment, and typically an ejection fraction of 30% would be considered to be a reasonable cutoff, though some devices will propose a slightly lower cutoff of 25%. Now, the problem with neo-left ventricular outflow tract obstruction is that the definition varies in the literature. Some reports will describe a neo-left ventricular outflow tract obstruction as being a greater than 10 millimeter increase in pressure pre and post-deployment, and this is one of the main reasons why patients are turned down for transcatheter mitral valve replacement therapy. The screening failure rate remains high at approximately 90%, with a simulated neo-left ventricular outflow tract area of less than 1.7 centimeters squared likely to be problematic. And this threshold gives a sensitivity of about 96% and a specificity of 92.3%. However, this is based on limited data and is limited because it does not account for left ventricular function, anterior leaflet stability, body surface area, and is not indeed patient-specific. We have to remember that outflow tract obstruction is a physiological phenomenon and not an anatomical phenomenon, and hence there is a need for more sophisticated computational techniques to better predict outflow tract gradients and geometric evaluation alone. So I suppose the question is, can we do better than geometric evaluation alone? And my personal belief is that I think we can. And this can be done by computer-specific modelling and also the incorporation of computational fluid dynamics. Now, what we are able to do nowadays is that by using a multi-phase ECG-gated cardiac CT dataset, along with incorporating transthoracic echocardiographic data, we are able to simulate blood flow in the left ventricle and what the blood flow and pressure and velocity will be following a transcatheter mitral valve deployment. On this slide was developed using multi-phase ECG-gated CT and also echocardiography. We can see that from the pre-procedural CT dataset, we can simulate what flow would be in the left ventricle following a transcatheter mitral valve deployment. And in this specific case, we can also model the mean and peak pressure gradients. This work has been extended to include more patients, and this slide just basically demonstrates the type of data that can be acquired using this specific technique. We use the aortomitral angulation, the mitral valve annulus area, the size of the left ventricle, the device-specific features, and also the pre-procedural echo data. And from this, we can look at the peak and mean pressure gradients from the pre-procedural CT scan and also look at residual blood volume, which may be an important factor for promoting thrombus in the left ventricle. Other techniques also exist to refine our planning for transcatheter mitral valve interventions. And one of the key areas of concern are patients who have mitral valve annulus calcification, and how can we improve outcomes for these patients. Fortunately, we're also able to incorporate computer simulation for these specific types of patients. And this work is conducted in conjunction with our collaborators FEOPS in Belgium. By using the CT dataset, we're able to perform CT segmentation and also to do a CT-based 3D reconstruction. From this, we're able to incorporate finite element modelling, which allows for the tissue-specific properties of the mitral valve annulus, the mitral valve leaflets, the chordae tendineae, and also the papillary muscles. Now, by incorporating the tissue-specific features, we can then virtually implant any specific device of our choice and measure the neo-left ventricular outflow tract area. Now, this can be seen on this following slide. We can see that if you vary the height of deployment on the pre-procedural CT scan using the computer simulation, you can get a variable neo-left ventricular outflow tract area. So on this slide, you can see on the left-hand image a mitral valve reconstruction with a mitral valve annulus calcification, and on the right-hand side, you can see a SAPIEN 3 being virtually implanted onto the simulated model. You can see the calcification here and the SAPIEN 3 valve. Now, in this specific example, we've implanted the valve at a low height, an intermediate height, and also a high deployment zone. Using this same technique, we can take pictures and views from the left atrium at low, intermediate, and high zones, and also a view from the aorta. And you can see how the neo-left ventricular outflow tract area changes with the deployment position from low, intermediate, to high. This technique can be used to measure at various different points the neo-left ventricular outflow tract area, which is going to be of specific relevance in patients undergoing transcatheter mitral valve replacement in mitral valve annulus calcification. So how does this differ from the existing techniques that we have, where you can virtually implant a cylinder on a cardiac CT dataset? The principal difference is that this is finite element modeling, so incorporates tissue-specific features. And on this slide, you can appreciate that the calcium is deforming following the device deployment. And this is of particular relevance to ensure that a particular individual does not get annulus rupture and there's not going to be any significant paravalvular regurgitation. So on the preceding slides, you can see that a whole array of different imaging modalities are available to us, which incorporate computational engineering and finite element modeling. However, I'm a strong believer that planning is one thing, but how can we ensure that the results that we produce in our imaging laboratories can be reproduced in the cardiac catheter laboratory? This is where I think CT fluorofusion really comes into its strength. We have to be able to ensure that the imaging and all of the planning that we've done laboriously over many hours before the procedure takes place is available for our interventional cardiology colleagues. So this is just one example of where the planning was used with finite element modeling, and we made a decision to proceed with a 29mm SAPIEN 3 valve. We recommended a medium implant position and that this would not introduce any outflow tract obstruction, there would be no risk of dislodgement and no paravalvular leak. Now, all of this planning is dependent on our interventional cardiology colleagues deploying the valve at the optimal projected position, which was a medium implant zone. And by a medium implant zone, I mean that the deployment is 50% in the left atrium and 50% in the left ventricle. So what we can do is to use all of the simulations that we've acquired using our FEOPS platform and our colleagues from Belgium, and to make this available for our interventional cardiologists directly in the cath lab with the Valve Assist platform courtesy of GE. So here we've done our segmentations of the CT scan. We've virtually implanted a SAPIEN 3 valve at our optimal deployment zone. By using the fluoroscopic simulation, what we can do is to predict the optimal fluoroscopic deployment zones and to make various specific markers on the CT dataset to make available for our interventional cardiology colleagues. So how does this look like in the real world? So here you can see on the left-hand image what our interventional cardiology colleagues would have if there was no fusion available. And on the right-hand image, you can see what happens when we make available using the Valve Assist platform the availability of landmark fusion. So I call this landmark fusion because here in the yellow line, you can see that I've delineated the superior vena cava boundary and the inferior vena cava boundary here. This reddish-pinkish line depicts the size and the shape of the left atrium. Over here, I've demarcated the fossa ovalis. In the blue, you can see the mitral valve annulus calcification, and the green line here indicates the lower optimal deployment zone of the SAPIEN 3 valve, and in the yellow line, the upper optimal deployment zone. So once again, on the optimal projection for deployment, you see what we have with no fusion, in the middle with volume rendered fusion, and on the right-hand image, you can see outline rendering for optimal visualization. Now we have a number of different options for our interventional cardiology colleagues, and much of this will be interventional cardiologist preference as to what type of imaging rendering they would like available for them. No fusion, landmark fusion, boundary fusion, and also volume rendered fusion to help guide their procedures. So here we can see that we can use the Valve Assist platform to ensure that we get optimal positioning of the device. On the left-hand image, you can see what the appearance would be with no fusion, and I think you can appreciate that it can be quite difficult to know exactly where to deploy the valve. Once we switch on our landmark fusion, we can very clearly see where the optimal targeted zone for deployment should be. We can see the upper margin and also the lower margin. And our interventional cardiologist can position the valve at the ideal deployment zone and then proceed to the deployment. Here you can see what the appearance would be with no fusion, with landmark fusion, and also with volume rendered fusion on the right-hand image as the valve itself is being deployed. We can also use the same technique to ensure that the simulation is verified at the very end of the procedure. We can now see that the SAPIEN 3 valve is deployed, and it has been deployed in the optimal position which was predicted by the simulation. And of course, any procedure that's performed in the cardiac catheter laboratory always needs verification with physiological imaging techniques, and this was the transesophageal echo imaging at the end of the procedure. Here we can see colour Doppler through the SAPIEN 3 valve, and that there's no significant paravalvular regurgitation or transvalvular regurgitation on the X-plane imaging in two orthogonal views, and once again on the right-hand side, an optimal deployment and an optimal result. And this is verified on the post-procedural CT scan, where we see the SAPIEN 3 valve deployed and no significant outflow tract obstruction and normal LV systolic function. So on the previous slides, we've seen how we can use multimodality imaging to help refine patient outcomes. But how do we actually incorporate this into our clinical practice in the real world? So this is an example of our King's Health Partner transcatheter mitral valve replacement or repair pipeline. So at our institute, we have a dedicated transcatheter mitral valve assessment clinic, which I run, and all patients who are referred to us have a one-stop clinical assessment. Now this includes a clinical history, a physical examination, same-day ECG, blood tests, symptom evaluation, a same-day transesophageal echocardiogram and transthoracic echocardiogram if indicated, and a full multi-phase ECG-gated cardiac CT. Once we've obtained the transthoracic imaging, we already have a good idea as to what type of strategy we're going to employ for this specific patient, and a preliminary discussion occurs with that patient as to what the potential therapeutic strategies are. The next step really is about having a think about the imaging in its entirety, the patient's specific condition and also their anatomical features, and also planning using our mitral valve toolbox. And this will be dependent at each institute based on the various technologies that you have available. Now, after we've considered what technologies we have available and what we think are available for the patient, we will then determine which of our imaging strategies we will incorporate above and beyond the basic imaging modalities that we have of cardiac CT, transthoracic echo, and also transesophageal echocardiography. And it is our practice to incorporate bioengineering and also imaging architecture into our patient pathway. And on some of the previous slides, you've seen our computer simulation, our computational fluid dynamics, static and dynamic modeling, and also the incorporation of CT fluoroimaging using the GE Valve Assist platform. We're now going to move over to some live questions and answers, and I'd be very happy to take some questions from any of those of you who've dialed in who may have any specific questions about the material we've covered so far. Hi, so good evening, and I'd be very happy to take any specific questions that may have arisen as a result of the first part of this live webinar for you. Okay, so we've had one question that's come through, and this question relates to what software we can do the CT fusion with, and as to whether or not this is only done with the FEOP software or it needs specific CT requirements. And just to stress that the CT fusion can be performed using CT DICOM data from any vendor, that can be GE, Siemens, Toshiba, or Philips indeed, and also fusion can be done with any specific software that you've processed your CT data set with. whether or not that is the FEOPS, whether that is through Mentio, or indeed the materialized platform as well. So we'll see for some further questions. So we have shown some examples. So one question has come through asking that could we explain the planning with computer simulation and CT fusion, and could this have similar benefits in other areas apart from transcatheter mitral valve replacement? Well, this session is really designed to look at its benefit on complex structural mitral interventions, but we have also used CT fusion and indeed echo fusion for different applications, and these extend to transcaval TAVI, left atrial appendage occlusion, and also interatrial septal procedures as well. So we've had an interesting question about what CT protocol do we use to acquire transcatheter mitral CT datasets. And we have a standardized protocol that seems to work for all of the different devices currently being experimented upon in the world for transcatheter procedures. Our specific practices, we use a Siemens scanner for our CT acquisitions for TMVR. We give 100 mils of contrast at 5 mils per second with the ROI, so bolus tracking, in the ascending aorta. Full retrospective with no dose modulations, acquiring at 5% phases. We also do include, I should add, a non-contrast CT scan of the thorax, which provides us thoracic anatomy to guide a transapical approach.
Calcification always left behind when replacing.
So we've had a question as to whether or not are the calcifications always left behind when replacing the mitral valve. So the one specific advantage of using finite element modeling, which you've seen on the FEOPS platform, is that it does account for tissue deformation and the various tissue properties that you have. So it will look at calcium deformation. We can't remove the calcium, but we can get an idea as to how it will deform following the SAPIEN 3 or another valve deployment in that position.
The echo imaging always same brand?
No, so the CT imaging with the fusion can be done with any vendor. The echo CT fusion, which we will show on the presentations, is done on the GE E95R3 platform. I'm not aware that CT echo fusion can be done on other vendors at present. So just to confirm that 3D echocardiography is indeed the fundamental for evaluating mitral valve physiology and also pathology. And our practice will always be to evaluate the severity, confirm the mechanism of the disease, first of all with transthoracic echocardiography, but also thereafter with transesophageal echocardiography. And that's of specific relevance to transcatheter mitral procedures, whether it's mitral valve annulus calcification or TMVR for functional mitral regurgitation, secondary mitral regurgitation. Where the CT comes into benefit is enhanced planning. So I don't think there is a preference amongst imaging modalities. I think all of the imaging modalities are complementary, but we do use the echo for the physiology, primary and foremost, and we use the cardiac CT for the high spatial resolution and the planning of the transthoracic approach and to help guide the procedure from its wider field of view. So which phases of the cardiac cycle do we acquire, and the measurements on CT, and what software do we use? So we acquire all phases of the cardiac cycle with transcatheter mitral valve planning. There is good data in the literature which suggests that the mitral valve annulus area will be larger at various points in the cardiac cycle, ranging from systole to early diastole. So it is important that you measure a number of different phases during the cardiac cycle that best represents the largest annulus area and annulus perimeter. So we would typically start off by doing 10, 20, 30, 40, up till 90% of the R2R interval. I would always start off by doing measurements at the 40% phase, but we'll always scan at the 20, 30% phase and the 50 and 60% phase to see whether or not the outflow tract looks smaller on manual assessment and whether that represents the largest annulus. Interestingly, we also have a comment from our colleague from FEOPS who's dialed in, and we are very keen and we're strong believers in using computer simulation and bioengineering, and he has given an offer that if anyone is interested And you'll see some more examples of the FEOPS platform on the next couple of presentations. To get in contact with FEOPS, if you want to trial this technology in the MAC position, they would be very happy to help you with any complex cases for this. So one question is, are the echo and imaging always the same brand, or is there cross-compatibility? There is cross-compatibility in terms of using echo and CT for transcatheter mitral evaluation. We have a number of different platforms available to us. When you're doing the echo CT fusion, which you'll see later on, you can use CT again from any vendor. So we show it on the E95R3, but you can use CT DICOM data from a Siemens, a Toshiba, GE scanners, and a Philips scanners as well. So is it mandatory to perform such complex planning for every TMVR procedure? So, I mean, our practice is always to get as much information as possible, and you'll see our approach on the next couple of presentations for some quite unique cases as to our precise sort of imaging approach for planning for these procedures. And we would always do TTE, TOE if we're going to be planning a TMVR, and always a multifunctional, a multi-phase ECG-gated cardiac CT. The simulation with FEOPS we would do for all of our MAC cases. We've been using them for probably 5 to 6 years now and find that exceptionally helpful. For the fusion cases, we can talk about the fusion after you've seen the next couple of presentations and which specific examples we would use that for. Okay, so in terms of time, I think we've covered the majority of the questions. We're now going to proceed to 2 of our case presentations, which hopefully will generate some further questions that we will be able to address on both of the specific cases and how we use the technology. So on the previous slides, we've covered about how we would approach planning for a transcatheter mitral valve replacement. But what I'd really like to demonstrate over the next 2 cases is an actual patient pathway with some patient history, clinical details, and what our precise step-by-step approach was for these patients. So the first case, which is case 1, is simultaneous transcatheter double valve treatment of severe calcific aortic and mitral valve stenosis secondary to mediastinal radiation. So the patient in question is a 61-year-old female who has a prior history of Hodgkin's lymphoma that was treated with mantle radiotherapy. She also has a prior history of a previous splenectomy. She was diagnosed as having mixed valvular heart disease with severe aortic stenosis with a mean gradient of 50 millimeters of mercury, and also severe mitral valve annulus calcification and also severe mitral stenosis. She had been turned down for surgery at multiple centers and had been deemed unsuitable for transcatheter intervention. She was eventually offered a high-risk surgical commando procedure as her only high-risk option, of which she was understandably reluctant to undertake. She was eventually reviewed at our institute for a further opinion regarding a potential transcatheter therapeutic option. So these were her laboratory investigations, nothing really remarkable on these. Her NT-proBNP was a little bit elevated at 786 nanograms per litre. So let's now move along to the interesting part, which is going to be the imaging. So this was her transthoracic echocardiographic imaging, and I think we can all appreciate here that there is extensive calcification over the entirety of the mitral valve annulus, extending over the aortomitral continuity and also into the aortic valve. There's preserved left ventricular function, and the left atrium is also a little bit dilated as well. As we looked in at the zoomed in view of the aortic valve, we can see that this is undoubtedly and unequivocally severe aortic stenosis with severe calcification of the right coronary cusp and also the non-coronary cusp, and reduced valvular leaflet excursion. In the short axis views, we can really appreciate the extent and severity of the mitral valve annulus calcification with a severely reduced mitral valve opening orifice area. We can see preserved biventricular function, and we can see incorporation of this calcification actually into the myocardium. And this is the short axis view of the aortic valve, once again severely calcified tricuspid aortic valve with a severely reduced opening orifice area. When we go to the apical 4-chamber view, we can once again see severe calcification of the mitral valve annulus, hyperdynamic RV function, small pericardial effusion, normal left ventricular function, but of concern on this particular case is a very small LV cavity. and this would ring an alarm bell or a red flag sign to me if I was planning for a transcatheter intervention, because this type of feature can be associated with significant outflow tract obstruction. When we move to the colour Doppler, we can see that there's a thin jet of mild regurgitation, which may be underrepresentative of the true degree as a result of shielding from the mitral valve annulus calcification. When we move to the CW Doppler across the mitral valve, we can confirm that this patient has severe mitral valve stenosis. The mean gradient on this particular study was 18 millimeters of mercury, and we can see the Doppler waveform which has been traced over on the CW. On the CW of the aortic valve, we can see and confirm that this is undoubtedly severe aortic stenosis with a Vmax velocity of 4.31 meters per second, giving a valve orifice area of 0.5 centimeters squared. So now let's move to the CT analysis, and I'm going to show you on this particular slide what my approach would be to interpreting the CT analysis. So we're using a multi-phase ECG-gated cardiac CT, and I've taken for this particular analysis a 40% phase, which would represent end systole. We can see the presence of a left-sided pleural effusion on this particular image, and we're just going to go through and scroll through the overall anatomy. So as we scroll through, you can see that this is a calcified aortic valve and that there is severe mitral valve annulus calcification, which extends through the circumferentiality of the mitral valve annulus. So what I'm doing here is just reviewing the mitral valve annulus calcification overall before I do a more detailed evaluation using our standard CT tools, which is multiplanar reformatted imaging. Now what I do is our standard approach. I place our crosshairs across the mitral valve annulus so I can bring out the mitral valve annulus calcification in its entirety. Now the key thing here when thinking about a valve deployment in mitral valve annulus calcification is to look not only at the extent and the distribution, but also what proportion of the mitral valve annulus is encompassed by the mitral valve calcification, because this is going to be the anchoring structure for a transcatheter mitral valve. What you will see here is that I've widened up the maximal intensity projection so I can get a more accurate, in my mind, depiction of the mitral valve annulus calcification. Now there is no set and hard fast rule of how you measure an annulus size in mitral valve annulus calcification, and this can be debated endlessly. So all I use this for is an approximation of size, and I use this approximation of size to determine what I think is going to be the likely optimal valve size. And this is going to be either a 23, 26, or in this case a 29 millimeter valve. Now once this is done, I'm now going to use a dedicated mitral valve analysis platform. This particular platform is Aquarius, platform by Terra Recon, which is a dedicated mitral valve planning platform. So the first thing I'm doing is I'm having a look at the overall anatomy of the left ventricle, and I'm now going to pull out the mitral valve annulus by simply clicking at the various annulus points. Now this automatically will trace around the mitral valve annulus in a 3D structure, taking account the vertical height and also the horizontal distance. And this gives me also approximation of our various measurements that we've deemed to be important, which is the septal lateral distance, the trigone to trigone distance, and the intercommissural distance. The software package also enables me to embed the selected valve type, and as we've seen on the previous slide, my crude CT analysis has suggested a 29 millimeter valve would probably be most appropriate. So I'm now moving the valve up and down from the left atrium to the left ventricle to look at an optimal deployment zone. In this case, it looks like a 50% deployment into the left atrium and 50% deployment into the left ventricle is going to be an optimal strategy. We can then automatically develop a curved line through the left ventricular outflow tract into the aorta and to measure the neo-left ventricular outflow tract area. And we can see that by doing this, and on the right-hand side you can see the red dot where I've made the measurement, it brings out a neo-left ventricular outflow tract area which is above the 1.7 centimeter threshold. So I have a reasonable degree of certainty that a 29 millimeter Sapien 3 valve will be able to fit in this particular patient without causing geometric outflow tract obstruction. Now you'll appreciate from my previous slides and from the introductory lectures that I don't believe in geometric evaluation alone, that I also think we need more sophisticated tools, particularly in these type of cases which are associated with a 50% mortality at 12 months. But before we come on to the more sophisticated analysis for the mitral valve, we mustn't forget that this patient had severe aortic stenosis, and so we needed to do our complete TAVI analysis, which involved not only an analysis of the peripheral vessels to make sure that we could gain adequate femoral access, but also an analysis of the basal annulus ring using the CT scan. And there weren't any specific issues on the TAVI CT planning. So let's now look at some of the advanced imaging planning that we incorporated in this particular case. So as we've previously discussed, we used our FEOPS platform, which is the finite element platform, to try and do some computer simulation to account for also the tissue properties of the mitral valve annulus calcification and mitral valve leaflets. Now here we can see is that we've implanted the 29mm SAPIEN 3 valve, and this online platform allows us to position the valve at various different heights from the left atrium into the left ventricle and to automatically measure the neo-left ventricular outflow tract area. And what we do is we move the valve at various different heights, and these are labelled as position A, B and C, to see what influence this has on the neo-left ventricular outflow tract area. Now reassuringly, this was concordant with the geometric analysis alone, giving us further reassurance that this case would be suitable for a valve in MAC procedure. As we've also seen is that we can also incorporate computational fluid dynamics, and what we've done in this particular case is that we've looked at the pre and post computational fluid dynamics simulations to ensure that there was not going to be a significant outflow tract obstruction following the deployment of a 29mm valve. And this technology allows us to measure peak and mean gradients in the left ventricular outflow tract from the pre-procedural CT dataset and also the pre-procedural transthoracic echocardiogram. It is also our practice, where possible, to obtain some 3D printing of these cases, and GE are also able to offer us some 3D prints, which allows enhanced visualization and manipulation of these models to see exactly what the specific anatomical considerations of a case are. Now, some of the more sort of state-of-the-art technology that we have in the pipeline in development with GE is also the availability of virtual reality. And the principles behind the virtual reality and all of the imaging techniques that you've seen is to make the imaging expertise available for use by the interventional cardiologist who is performing the procedure. It's very clear that imaging cardiologists have a wealth of experience in analysing CT datasets and echocardiographic CT datasets, but the real sort of goal in all of this is making sure that that information is communicated adequately and effectively to our colleagues who are going to be performing their procedures, because invariably and inevitably that is anticipated to improve procedural outcomes. And here we can see Professor Redwood using our virtual reality platform to try and understand the anatomy better before he actually proceeds to the case. Now, the procedural strategy that was eventually determined was that this case was going to be done under a general anaesthetic with TOE guidance. We were going to do a simultaneous case of a TAVI procedure first, ultrasound-guided left transfemoral access, followed by sentinel protection, coronary angiography, no balloon aortic valvuloplasty before the TAVI valve, and then a 23mm SAPIEN 3 TAVI valve deployment from the left primary access. The strategy was that if the TAVI procedure went well, we would proceed immediately thereafter to a valve in MAC procedure with the Valve Assist CT Fusion imaging platform using the simulation fusion. This would be done with a transeptal puncture and an atrial septostomy, and the delivery of a 29mm SAPIEN 3 valve in the mitral position, aiming for a moderate to high LA implant as per predicted by the computational modelling on the FEOPS platform. Single ProGlide and 8 French angioceal closure device through the right femoral artery with a single ProGlide through the right femoral vein, and there was formal surgical backup available with an option for cardiopulmonary bypass if required, as would be the norm in all cases which are associated with a high complication rate. So how did we do the CT fusion imaging? So on this slide we're going to take you through an actual step-by-step approach as to how we do CT fusion imaging. So this is the Valve Assist platform. Now the Valve Assist platform automatically segments the left atrium once this is loaded up onto the platform. And the manual step is to segment out the mitral valve annulus calcification, which you can see myself doing here, and this is depicted by the blue. The next step is to actually segment out and do pixel mapping of the segmented SAPIEN 3 valve, and we're now encoding the sapien 3 valve in the mitral valve annulus calcification position and including the aorta for some more reference points. The next step is to make sure that we have some planning lines. So what we're doing is tracing around the lower optimal deployment zone and also the upper optimal deployment zone to provide some landmarks for the interventional cardiologist in the cardiac cath lab. We can then use the platform before the procedure to make sure that we have the optimal fluoroscopic projections. We're now also doing some further planning, and we're marking the optimal transeptal puncture point with a fossa ovalis. Here you can see at the top we see the superior vena cava, which has been depicted, the inferior vena cava, the fossa ovalis, and also the specific TAVI valve in situ. Now once you've done this pre-procedural step, this procedural step takes about 10 minutes or 5 minutes if you're very slick and used to the platform. We now then need to do the most crucial step, which is to make sure that the fusion is satisfactory and accurate for the interventional cardiologist. Now, this is actually a very simple approach. Once all of the segmentation and preparation has been done on the Valve Assist platform, that typically takes no longer than 5 to 10 minutes, the next step is the procedural fusion before the procedure starts. This is generally a very quick process and only takes 2 different views, one view in the REO view, one view in the LAO view, and we bring up our pre-procedural segmentation, and this is then co-registered. So what you will see here on the left-hand image is us bringing up the segmentations, and once the segmentations have been brought up, this is positioned on one view on the left-hand side first of all, over the mitral valve annulus calcification as such, and then on the other view, which is the LAO view, so you have 2 fusion registrations. Once this is done, this will track the procedure throughout the duration, and this fusion will be reliable irrespective of what LAO caudal view you have or whether you are cranial or caudal. So we're now moving on to the procedure itself, and this is now Professor Simon Redwood and Professor Bernard Prendergast, our 2 structural interventional cardiologists, first of all deploying the TAVI valve as per the procedural plan. What we're going to do during this video is really just to focus on the imaging aspects rather than the technical case, which has already been described elsewhere. So we can see that the TAVI valve has been deployed satisfactorily, and so the next steps as planned is that we would move directly to perform the valve in MAC procedure. Now it's very interesting, in this particular case we had access to our E95R3, which has the capability of blood speckle imaging, and we'll talk a little bit more about blood speckle imaging on the next case, but this is essentially a visualization modality that incorporates 3D color Doppler flow and is not angle dependent, and it's also acquired at a high flow rate. So on the bottom left-hand image we can see that we're also looking at the left atrial appendage. There was a concern as to whether or not there would be left atrial appendage thrombus in this specific case, particularly in patients who have significant mitral valve stenosis and mitral valve pathology. So we're now getting our optimal fluoroscopic projections. We know the fusion has already been done, and then the interventional cardiologist will then rotate the image to get the optimal angles for their subsequent steps in their procedure. So here we can see on the right-hand image our planning lines, which were pre-prepared, and also the segmentation of the left atrium. If you remember that we've got the orange line that represents the optimal superior margin of the deployment, the blue line the inferior margin, the little red circle the fossa ovalis, and the SVC and also the IVC depicted by the purple and white lines. We've now also just slightly dimmed the volume rendering fusion just to provide some enhanced visualization so it doesn't obscure the fluoroscopy images for our interventional cardiologists. And this is completely customizable on the Valve Assist platform. We've now increased the density so we can see the calcification more clearly, and our interventional cardiologists are now performing their appropriate positioning and getting the guide wire in situ. Now, Professor Redwood and Professor Prendergast are now performing the atrial septostomy, and this is just to enable passage of the sheath across the interatrial septum. What we'll now see on the next couple of slides is that the TAVI valve is going to be introduced across the interatrial septum and positioned at the optimal target zone using the Valve Assist simulation and CT fluoro fusion platform. So we can clearly see this was quite a challenging case to make sure that we had adequate support. But now we can see that the Sapien 3 valve is positioned at the optimal zone, and now what will happen is that the valve will be deployed in the optimal projected position. And as it's being inflated, Professor Redwood and Professor Prendergast are making sure that the valve tries to remain within those deployment zones, because we know that that is where we will get an optimal result. So it's slowly being positioned within those zones, and the final result was that it was deployed adequately and satisfactorily with an excellent final result that was confirmed on the post-procedural imaging. So we're now going to move to the post-procedural transthoracic echocardiogram. We can now see that the 29mm Sapien 3 valve is in situ on the left-hand image, and on the right-hand image there is no colour Doppler flow acceleration in the left ventricular outflow tract and no significant specific issues. We move to the 4-chamber views. We can see lovely laminar flow through the Sapien 3 valve with no significant regurgitation and no flow acceleration in the left ventricular outflow tract, which was one of the primary concerns. So we're now going to open the webinar to some further questions, and I'd be happy to take any specific questions or answers regarding this specific case, and also the use of CT fluorofusion. Hi, so hopefully you enjoyed us demonstrating some of the different imaging modalities and how they fit into our patient pathway, and we'd be very open to any specific questions regarding that last case that we've done. To put things in context, we have done a number of valve in MAC cases, and that would be our standard procedure for all of the valve in MAC cases, is to do the echocardiography, to do the CT scan, to do the Terra Recon or Aquarius Intuition, doing the simulated implant, followed by finite element modeling is standard practice for us here with FEOPS, and then we would also try to do the computational fluid dynamics and the 4D flow. Now, the 4D flow on CT is very much a research tool. It is something we have been developing. It takes about 30 days to get a result. So what we normally say is that for the complex cases, if you want all of the advanced bioengineering solutions, we ask our operators to give us at least 3 to 4 weeks to be able to prepare the full spectrum of imaging that we have available. Someone has asked on the question stream as to what time frame is it to get the FEOPS modeling and the computer simulation and the platform that we demonstrated. That normally is quite quick. It's all dependent on the quality of the CT scan acquisition and also the data that is sent to FEOPS in terms of the visual interpretation to start off with. We have had cases rushed through within 48 hours, which is a remarkable turnaround frame, but I would generally advise that you probably need to give 1 to 2 weeks, ideally, to make sure you get the right simulations and you can interact with the company to make sure you understand the platform and can do the appropriate planning. CT fusion is another question that has come up as to what proportion of cases do we actually use the fluoro CT fusion for? Does it need to be used for all cases? I don't think it does. I think the two main benefits for the CT fusion for us is, number one, to facilitate training when you're trying to enable your interventional cardiologist access to the data and information that you've seen in your pre-planning. Also for the complicated cases as well, I think it's invaluable. So for any complicated case that we think is going to be challenging when we've done our pre-procedural analysis, we would always offer the CT fusion to our interventional cardiologists. And in particular, where we have found it useful will be the transcable TAVIs, where you can clearly put the abdominal aorta on the fluoro, see the points of calcification and the areas to avoid, and also for the transcatheter mitral cases. Not so imperative for valve in the mitral, not so imperative for TAVI if you're an experienced operator, but the more sort of bespoke, the more unusual indications which you're worried about, then I think it's absolutely invaluable to be using and incorporating into your practice. So we have a few further questions. So how long did the procedure take? Yes, so that's a very good question. So we've shown a very condensed clip on this case purely for the time's sake. The procedure, it was a very complicated procedure. The total time to do the procedure, which was the TAVI followed by the valve in MAC, the total procedure time was about 1.5 hours. So we wanted to be certain that the TAVI was done successfully. and then the valve in MAC was done successfully. The main challenge, as you will have noticed for the astute-eyed, is that getting adequate support for the valve deployment, the valve in MAC, it needed to be railroaded down the ascending aorta with an additional guide wire support, and then to maintain the coaxiality. So it was a long procedure, 1.5 hours to do both. And we had planned to do the TAVI first, if that was uncomplicated and successful, to proceed to the valve in MAC. So there are complications given by circumflex coronary artery during the procedure. Yes, that is absolutely correct. So also the thing we haven't included is the circumflex analyses that we would do. When we're looking at the multi-phase cardiac CT scans, we will always take reference to the circumflex, the distance from the mitral valve annulus, both in vertical and horizontal height, in terms of various phases of the cardiac cycle. Because as you expand the 29mm sapien 3 in the MAC position, you will get an outward expansion of that valve in the mitral valve annulus position, potentially posing a risk to the circumflex artery. So we will note if the patient has a bypass graft onto the OM1 or the distal left circumflex, whether it's a right or left dominant coronary circulation. So that's a very good point to mention. So yes, so I think the image quality, can it get better than it currently is? That's a very good question. So I think much is dependent for all of the modeling and the computational simulations on the quality of the CT scan acquisition and the data that you provide industry, so FEOPS and also for doing the CT fusion imaging. We use high-end CT scanners, but I think third and fourth generation scanners are now used commonly at most of our cardiovascular institutes that do complex structural interventions. So we have shown that the sapien valve with a yellow color and made pixel-based segmentation on the 3D scan. When did this segmentation actually happen? So this particular case, as you noticed, we did the computational simulation with FEOPS first of all. We then transfer our DICOM dataset of the computer simulation from FEOPS onto the GE Valve Assist platform. So we have the segmentations of the valve in the optimal position all ready for the CT fusion. We then do the segmentation and do the pixelation of the pre-planned computer-modeled sapien 3 valve in situ. Okay, so in terms of time, once again, we're going to move on to our second case for this evening. And this is quite, again, a unique case which poses a specific challenge to our interventional cardiologists. And we'll take you through the imaging planning steps once again for this. Okay, so we're now going to move on to my second case for this webinar. And this case is entitled Willful Anterior Caudal Repositioning to Facilitate Mitral Valve in-Valve Implantation. So let's consider this patient. So this patient is a 71-year-old man who underwent a 31mm Carpentier-Edwards pericardial valve for secondary mitral valve regurgitation in 2002. He thereafter developed heart failure and underwent CRTD implantation in 2016. He's known to have moderate to severe biventricular systolic impairment. He has established COPD but gave up smoking in 2019, rheumatoid arthritis, and also intermittent claudication. So let's look at some of his clinical evaluation. So reasonable height of 176 centimeters, reasonable weight 75.6 kilograms, normal BMI at 24.4. Has obstructive airways disease with an FEV1 of 1.52 and a peak flow of 332. Was an NYHA class 3 when I saw him, had symptoms of paroxysmal nocturnal dyspnea and an exercise tolerance of only 50 yards. On examination, he had a clear, loud, early diastolic murmur in keeping with mitral stenosis, and so we planned for him to undergo transthoracic echocardiography and also multi-phase ECG-gated cardiac CT. So here we have the apical four-chambers views. On the left-hand side, we can see the apical four-chamber view without color Doppler, and on the right-hand side with the color Doppler. We can see that the prosthetic mitral valve appears bulky. There is also some suggestion of there being early cord insertion onto the anterior post of the frame. Here we can see the flow acceleration through the prosthetic mitral valve, and this gave a mean gradient of 11 millimeters of mercury. We now move to the two-chamber view. We can see once again that there's abnormal cords inserting into the frame of the sewing ring of the prosthetic mitral valve, and also once again in a slightly modified apical three-chamber view, cords inserting onto the anterior post of the prosthetic mitral valve. So this case posed a specific challenge, so we proceeded to perform multi-phase ECG-gated cardiac CT, and this is my real-life analysis for you. So I'm scrolling through the axial CT dataset to obtain some appreciation of the overall anatomy, and we can see already as we scroll down the cords from the anterolateral wall inserting to the anterior post of the sewing ring of the mitral valve. We're now going to zoom in onto the valve and to have a closer look using our multiplanar reformatted tools, and we're just rotating our crosshairs to be aligned with the apex of the left ventricle so we can see the mitral valve in the short axis. So now the crosshairs are positioned, I'm just changing my window width and levels, and we can now see this echo density on the bottom right hand image, which reflects the cords inserting into the cusp, into the internal ring of the sewing ring. Shortly I'll play some cine images which shows that this caudal insertion onto the prosthetic mitral valve actually resulted in leaflet restriction. Furthermore, given the age of the valve, there was also evidence of degeneration of the valve and also calcification. So here on the cine imaging you can actually see beautifully that the cords are inserting onto the anterior post of the prosthetic mitral valve, and this was acting like a trampoline and preventing the leaflet opening of the prosthetic mitral valve. And you can see the echo density of the leaflets there. So once again we're looking at the prosthetic mitral valve opening, and we can see that there's leaflet restriction. Full leaflet restriction of the anterior cusp, further restriction of the septal cusp, but fully free movement of the posterior cusp of the prosthetic valve. We're now going to move to perform our dedicated mitral analysis using our mitral valve platform. And we're starting off just by having once again an overall look at the anatomy. We're now going to place our crosshairs aligned with the mitral valve annulus and have an overall look at the geometry and the architecture of the left ventricle, with particular relevance of the papillary muscles, the cords, and also the neo-left ventricular outflow tract. Now, although I know the size required for this particular valve using Mr. Bapat's excellent valve and valve app, I also do my own crude measurements because I want to perform some simulation of implanting a valve actually inside this ring. So once we've pulled out our estimated sizing, the next step will be to virtually implant a 29mm Sapien 3-cylinder inside this mitral valve. So I've now done this. I'm now going to move the position to a position that I think is going to be optimal for this patient to ensure good device stability. And once this is done, we're then going to measure the neo-left ventricular outflow tract. So we've now pulled out a curved MPR, and we're now going to move to the relevant point. You can see that as the pink dot. I'm just closely positioning that and just tracing around and adjusting the lines, and we have an adequate neo-left ventricular outflow tract, and we can pull up all of our measurements on one screen. So after we've done our conventional CT analysis and we've done our simulated valve implantation, what we wanted to do is to ensure that this information was available for our interventional cardiologists in the cardiac cath lab. And we used our complete spectrum of fusion capabilities for this specific case. So on the bottom left-hand image, as you've seen on the previous case, we started off with 5 to 10 minutes of preparation to do our various segmentations. Now this is our pre-prepared segmentation, and what we've done is we've pulled out the aorta in the previous case. We can see the left atrium and the left ventricle, and we've also mapped in the prosthetic mitral valve. What we did additionally for this case is to also map in the two cords that we were concerned about, and these are illustrated by the green and also orange line. Once again, we have our fossa ovalis at the optimal septal puncture point, the SVC, and also the IVC. Now on the middle image, what you can see again is our planning lines, and we were very fortunate that we were able to label the cusps individually so we could communicate this to our interventional cardiologist in the cardiac cath lab to depict and also to denote which leaflets were of particular concern. If you recall, we had one completely restricted leaflet, one partially restricted leaflet, and one leaflet that functioned normally. Now we also noted interestingly on this particular case that on the CT scan there was also calcification at the interatrial septum, and this became an important point to illustrate to our interventional cardiologists that to obtain an adequate transeptal puncture, this calcification would need to be avoided and may not be easily visualizable on the fluoroscopy alone. So we marked our phosphorovale distant to the calcification to ensure that this would not be a specific issue. Now, once the valve assist platform had been used, we'd done our planning lines, the next step was to import this planning onto our E95G Vivid echo system, so we would have available the echo and CT alongside one another on the one platform, and that these images could be fused together. This would then enable us to have real-life CT fluorofusion and also real-time echo CT fusion, which could be displayed for our interventional cardiologists to provide the maximal information. So let's first of all look as to how we did our registration, the CT fluoro on the Valve Assist platform. You will recall that this is a very simple process where you take one RAO view, one LAO view, you move your segmentation to the appropriate point on the fluoroscopy image, and then the fusion is done, and this will track any rotation of the gantry while the procedure is being performed. You can see beautifully here that what we decided to do, and this is very customizable as per your preferences, is to include the SVC margin. We've got the fossa ovalis, the calcification at the interatrial septum, we've got the prosthetic mitral valve, the leaflets clearly labelled 1, 2 and 3, and also the chords. And the second angulation is just showing the different view of this to make sure that we can get an optimal fluoroscopic projection. Now, the peri-procedural TOE, these are images taken from our E95, first of all confirmed the findings that we'd seen on the functional CT dataset. We can see that the mitral valve was restricted and there was also calcification of the leaflets. Now, this gave a mean gradient on the transthoracic echocardiogram of 11 millimeters of mercury and coincided with a progressive increase in symptoms over the previous 2 years. On the right-hand image, you can see on the multidimensional view the restricted leaflet opening, which is actually buttressed by the caudal insertion into the sewing ring of the prosthetic mitral valve. So this is just some of the measurements. We can see that there is some mild regurgitation, and we can also see that actually during the procedure the mean gradient was 6 millimeters of mercury, which is not an uncommon finding under conditions of anesthesia and also sedation. Now, blood speckle imaging, which I'm going to show on some of the forthcoming slides, is a blood flow visualization technique that overcomes the Doppler angle dependency, which only normally incorporates radial velocities which are calculated and displayed. It also overcomes issues with aliasing as well. Blood speckle imaging uses ultra-high frame rates using a technology known as plane wave imaging, and it tracks the moving blood cells from one frame to the next. The particular advantage of this technique in terms of visualization is that it's allowing you to look at blood flow in 3 dimensions at very high frame rates. So this is just an example of what blood speckle imaging looks like in our specific case, and 2 different types of blood speckle imaging technologies. Now, on the left-hand image, we can see line rendering, blood speckle imaging, and on the right-hand imaging, arrow rendering, which clearly depicts the direction of blood flow very clearly in the left ventricle as it passes through the prosthetic mitral valve. And this type of visualization technique at the moment is used predominantly to convey very accurate information and to show and display velocity of blood cells through various structures of the heart accurately to our interventional cardiologists. We're now moving to our 3D analysis of this patient's prosthetic mitral valve. We can clearly see a restriction of the septal leaflet on the 3-dimensional image, and we can see a partial restriction of the septal leaflet and freely opening posterior leaflet. On the colour Doppler flow, as we've seen, we can see that there's mild mitral regurgitation. So what we also wanted to do for this case was echo CT fusion to maximise the information that we could give our interventional cardiologists. And this works on a very similar principle to the previous slides that you've seen on CT fluorofusion. So let me take you through this in real time as to how this is actually done on the E95 Vivid platform. So the first step in any fusion process is to make sure that you have all of the imaging modalities available to you. So what we had done is we'd taken our CT scan, and this can be from any vendor, and this is imported onto the echo machine as long as it's a valid DICOM dataset. Once it is opened up onto the echo machine, what we then do is to follow the pictograms. So what you will see me doing in the next 30 seconds or so is adjusting my images in each of the 3 imaging planes to make sure that they match the pictograms that you see. What we will then do is to label the various structures using the specific workflows that are available to us on the right-hand side. So, as you can see, the first thing we're doing is we're showing you exactly which of the pictograms we're going to be followed. So we first of all rotate our various images that we have from the CT scan to make sure that they match the various pictures that we have. So we can see here that this is a two-chamber view, so we're making sure we have a two-chamber view on the bottom left-hand image. We're then marking our various structures, and you can see posterior, anterior, and also aorta. What we then do is to acquire a four-dimensional echo image, and we do the same thing again, and we mark the various structures using the same annotations that we've used on the CT scan. Now the machine will then cleverly co-register the CT and the echo images together, and we do a few minor adjustments to make sure that the registration has been appropriate, and we're then ready to go. So it's a relatively quick and simple process, but it provides a wealth of information and also allows you to be able to adjust the rendering options and the visualization options, which are customizable for the viewer. And you'll see on the subsequent slides the type of data that can be made available for our interventional cardiologists. So once our echo CT fusion has been done, we're really ready to go. Now what we can see on this slide is the four-dimensional echo image on the left-hand image, and we can see the CT echo fused image on the right-hand side. So once again, we're incorporating two imaging modalities and portraying that imaging to our interventional cardiologists. Now I think a logical question is that why is this required? Well, I think you're using the virtues of the different imaging modalities. You have the high frame rate from the echocardiogram and also the physiological information of the moving structures, along with the high spatial resolution of cardiac CT. You will appreciate that on transesophageal echocardiogram, you have a limited field of view, you have a limited view of the surrounding structures. But with the CT scan, you have the entire cardiac anatomy and adjacent anatomy, so you can appreciate the surrounding structures and also the anatomical orientation of various structures within the thoracic cavity. So what we can also do, which is a nice feature, which we like to do quite frequently, is to annotate various structures, because as you change the views on the transesophageal probe, you can often get lost in terms of what structures you're specifically looking at. Now what we can see here is that we've annotated the left superior pulmonary vein and the left atrial appendage in different colours. We've got the left atrial appendage in red, and we've got the left superior pulmonary vein in yellow. Now, irrespective of which view you look at, this colour coding remains throughout the transesophageal images, so you never get lost in terms of what structures you're looking at. Now, of interest, you can see that there is some echo density in the left atrial appendage. This is actually very dense spontaneous echo contrast on the TOE rather than thrombus, and that just reflects the static blood flow and low velocity blood flow in the left atrium. So let's move on to the procedure itself and how all of this sophisticated imaging technology was used. So we visualized the transeptal puncture both in 2D and 4D and showed the perspective and distance to the mitral valve. And you can see here the transeptal puncture and the catheter passing down, and you can see the superior margin of the prosthetic valve over here through the left atrial appendage view. Now once this was done, we were going to use the Valve Assist platform, and you've seen that we've already done our pre-segmentation, and we've got our calcification, which I've pointed out already over the intraatrial septum. We have our left atrial structures here, left atrial appendage, and we have the prosthetic mitral valve. Now on the Valve Assist platform, we also planned the transeptal puncture, and we were also able to point out using the CT and the TOE exactly where the calcification was, and this area could be avoided. I think you can appreciate that if you used the transesophageal echo images alone, you cannot appreciate the subtle calcification over the intraatrial septum. Once you actually incorporate the CT with the echo dataset, you know precisely which areas to avoid. So we're now moving to catheter positioning in the mitral valve. We used both the two-dimensional and three-dimensional images to confirm the catheter position. The third video that you see here is the view from the mitral valve, and here you see the view from the left ventricle, so you can analyse all steps of the procedure using whichever views that you wish to. Now, the first step in this particular case is we were concerned that if we implanted a transcatheter valve directly into this valve, the abnormal caudal insertion may have acted as a trampoline and caused device dislodgement. So we elected to try and reposition the cords in the first instance to introduce a bit of laxity and flexibility to the cords to prevent this occurrence from happening. And the intent was to do a balloon mitral valvuloplasty to separate the cords, followed by the implantation of a transcatheter mitral valve. Now, the problem that we encountered or potentially expected is that once we repositioned the cords, we may have been left with severe mitral valve regurgitation, and so we were ready to deploy the valve once the caudal repositioning had occurred. Now here we can see the wire passing through the mitral valve, both on the four-dimensional echo, on the CT fluorofusion, the gradients that were measured, and also the landmark fusion that was used to guide this procedure. So you can see the guide wire across the mitral valve prosthesis. We're going to avoid this calcification. The valve is then going to be positioned exactly where we want it to go, and then the valve will be deployed as intended. Now, we started off with the balloon inflation, as I've mentioned, and I'll allow this video to play so you can see the balloon inflation occurring with the enhanced visualization in place. So there the balloon is inflated, and that is just separating the cords to introduce this flexibility and laxity to the cords to mitigate any risk of device deployment after it's inflated into the valve. So here we're looking at the echo assessment post-balloon inflation, both on the two-dimensional images at the 140-degree view in the long axis view on the transesophageal echo, and also the four-dimensional view here on the right-hand image, which also gives us the multi-dimensional view option on the left-hand side. So the balloon inflation was successful. The gradient was 3.7 millimeters of mercury, so a good result from the pre-procedural case, and we then performed some blood speckle imaging to see what changes there were on the four-dimensional blood flow through the valve using this visualization technique that we've already discussed. So after this was done, we moved to the valve deployment. Once again, this was done with the CT Echo Fusion using the Valve Assist platform and also the CT Fluorofusion platform. We can see the valve being inflated on the left-hand side, and we can see all of the clear anatomical landmarks, which just makes the information transition to the interventional cardiologist that much easier. We monitored the procedure with real-time TOE to make sure we weren't going to get any complications. As I mentioned, this was considered to be a high-risk procedure. We were concerned about device dislodgement, so it makes sense to have also real-time TOE available for your operators. Okay, so this is the echo assessment by transesophageal echocardiography post-valve deployment. We know that the valve was successfully deployed, and this was confirmed not only by the two-dimensional echocardiogram, but also by the blood speckle imaging. We can see that there is a trivial amount of paraprosthetic mitral valve regurgitation. This was not felt to be significant, but good forward velocities through the valve with no significant obstruction, and a good result on blood speckle imaging with nice laminar four-dimensional flow across the valve. Now this is the four-dimensional, three-dimensional TOE imaging on our GE machine. We can see that the valve leaflets are opening beautifully. There's only a trivial amount of regurgitation, which after the nitinol frame is expanded actually became obliterated. So a very good result from the procedure with no specific paravalvular regurgitation at 1 minute following device deployment. Okay, and as our final check, we performed fusion assessment using the CT Fluorofusion and Echo CT Fusion following the valve deployment, and we can see that the valve is beautifully deployed with our anatomical landmarks on the CT Fluorofusion, and on the Echo CT Fusion we can see the final appearances on the imaging modalities that we've used. So to conclude, hopefully over the last hour or so you will have seen an approach to evaluate patients for complex transcatheter mitral valve interventions and learnt a little bit more about some of the enhanced visualization tools that we have available, and also computer processing engineering tools that are currently being explored into current clinical practice. What do I see as being the key virtues of a successful structural imager? Well, I think first of all this has to be effective communication. We are experts in our field, whether it be echocardiography, multimodality imaging, or cardiac CT, or even indeed cardiac magnetic resonance imaging. However, the importance is communicating our information and expertise for the benefit to the interventional cardiologists and directly to them in the cardiac catheterization laboratories. I believe that if we can communicate effectively our expertise and experience and make it available, we can enhance procedural and patient outcomes and also maximize all of the benefits of our hard work that goes into pre-procedural imaging planning. I think this can be achieved with not only having exemplary skills in multimodality imaging, but also using what tools and facilities are available to us to make sure that that information is made available to those performing the procedure. And a specific example of doing this is with enabling the usage of CT fluorofusion imaging and also CT echofusion imaging and all of the enhanced visualization tools that you've seen so far. I think it would now be a good opportunity to open the floor to some questions, and I'd be happy to take any questions that you may have, either on transcatheter mitral planning or any of the cases that you've seen, or the practicalities about incorporating some of these imaging modalities and techniques into your current clinical practice. Okay, so I've given a webinar on transcatheter mitral valve planning, the incorporation of finite element modeling, computational modeling, and I've also demonstrated two cases where CT fluorofusion, CT echofusion could be used to help plan for complex cases. Now, we've had a few questions that have come up, which I wasn't able to answer the previous time around because the questions came through the portal slightly late. So I'll try and address a few of those questions now. So someone has asked, what is the cost of doing all of the bioengineering and using some of the techniques that we've demonstrated? So it's essentially cost neutral. So for the finite element modeling with FEOPS, that's provided as a service because it's still in an experimental stage, that we use it for clinical practice based on our experience, but they would be happy to work with you, I think, to gain expertise, because we're strong believers in this approach for structural interventions. For the 4D blood flow from cardiac CT, that's a research tool. It's done in-house, so that is cost neutral. The fluorofusion, echofusion, that usually comes with the various platform that you have. So if you are buying a fluoroscopy unit for your cardiac cath lab, that would be included in your negotiations to have that installed in your facility. In terms of the time to do CT echofusion, how long does it take in real practice? It usually has no interruption to the workflows. The only real procedural step is to upload the CT DICOM dataset onto your echo platform, and then you can do the live fusion. And the steps that I demonstrated on the second case is a live demonstration of how long it takes to actually set up the fusion. So it has no interruption to your standard workflow. We have a few other questions that have come through. We've demonstrated the blood speckle imaging. How do we use that in current clinical practice? So at the moment, I see blood speckle imaging as being a visualization tool, but there is a lot of work underway at the moment with GE and other partners to see whether or not different sort of data can be derived from using this technique in current practice. So velocity data and also looking at how blood flow vortices impact upon prosthetic valve degeneration and impact upon LV recovery following device deployment, particularly in the mitral valve position, and also to better quantify aortic valve stenosis and correlate that with 4D magnetic resonance flow. So, okay, so that's we've had a very good question. So first of all, there is no significant cost increment to incorporating these imaging modalities apart from having the hardware and the latest CT scanning software and echo machines available. How much time do I spend on all of the CT processing? So that's TeraRecon to derive all the necessary recons for a single patient. So how long would I spend doing a transcatheter mitral valve analysis? So I think to do a full transcatheter mitral valve analysis, looking at all of the various aspects to derive a report, that would probably take me 20 to 30 minutes on a dedicated platform. Most of the measurements are done very fast with automated software packages. The more sophisticated tools take longer, they need to be sent away. So I would normally tell my interventional cardiologist that for a full plan, which would incorporate predictions of flow, modeling, simulations, and a degree of certainty as to what the outcome would be, I would ideally like 1 to 2 weeks to get everything together for them. The actual CT processing, whether it's 3-Mencio, whether it's materialized, whether it's TeraRecon, is the fastest step in the process. that takes 20 to 30 minutes, but also it is the most crude of the processes, and it is anatomical measurements, which I don't particularly rely too much on to do my planning. So another question, how many people is concurrently working in the cath lab in a mitral in-valve procedures? Do these occur in a hybrid cath lab or a simple cardiac cath lab? So I would say that we would have, for a complex transcatheter mitral, we would have one TOE operator, we would have 2 interventional cardiologists, the radiographer, probably 1 structural interventional fellow, and myself would be sitting in the control room providing further guidance as and when required with the CT fusion. So for all complicated cases, I think the role of the pre-procedural planner, such as myself, is not only to do the pre-procedural planning, but is also to understand what steps are important for the interventional cardiologist, so you can better guide the cardiologist at the time of the procedure. So before any case, I'd be sitting down with our interventional cardiologists, going through all of the imaging that we've done on a PowerPoint presentation or showing them the videos, and highlighting any specific areas of concern, and also showcasing to them what the appearances will be once the fusion is overlaid with the fluoro, and what to expect and how to use it for that specific case. So that's where my role would come in as an architect being in the cath lab for the case. So all of our cases are currently done, if we don't expect the patient to be needing to go to urgent recovery or rescue surgery, would be done in our standard cardiac catheterization laboratory.
That's just a new one.
Okay. So do we plan and perform truly hybrid procedures where open heart surgery is involved? So once again, a very good question. So I think this is really where the pre-procedural imaging planning comes into its forte. So as well as doing the pre-procedural imaging planning, we will, based on experience and using all of the modeling that we have, predict the likelihood of there being a necessary required surgical bailout. If we think the procedure is exceptionally high risk, we would always have a surgeon on standby in the cardiac catheterization laboratory during the key steps. We don't particularly use the hybrid lab frequently because most of these cases will be done in our standard cardiac catheterization laboratory. The advantage, paradoxically, of having all of these sophisticated pre-procedural steps is you know which cases you can do reasonably safely and with a reasonable degree of accuracy in a standard cardiac cath lab, rather than that uncertainty with not having all of these tools available, where you may be inclined to use a hybrid lab and rush a patient to surgery or need a surgical bailout. So far, I can't remember the last case where we have required a surgical bailout when all of this sophisticated imaging has been used for the pre-planning. I think it's important because as a result of having all of these tools, what will happen is that you will filter out patients who, 100% would not be suitable for a transcatheter approach. So, if I've done 15 valve in MAC cases, I will probably only recommend 40% of those cases to go forward for a valve in MAC procedure. 60% of those cases will be turned down after pre-procedural planning. Now, in the past, when we did not have all of these pre-procedural tools, some of these patients would invariably have been listed for a valve in MAC procedure, and some of those patients will have developed significant paravalvular regurgitation, device dislodgement, annulus rupture, compromise of the left circumflex, and have been rushed to intensive care or indeed surgery as a bailout with a suboptimal patient outcome. Okay, so I think we have definitely overrun today, and my sincere apologies for that, but it's been very good to spend this hour and a bit with all of you to showcase some of our imaging technologies and the King's Health Partners approach to transcatheter mitral planning. I do hope you've enjoyed some of the cases and the steps that we've demonstrated, and please feel free that if you have any further questions, please feel free to contact me either via email or LinkedIn or via the internet. I'd be happy to take any further questions that you may have, or to help you plan some complicated cases that you may have. We do provide and have helped other centres in the past from the UK, Asia and also China when they've had complicated cases, whether they're uncertain as to whether or not these cases would be suitable for certain cases. We can, in a limited number of cases, extend some of our facilities and techniques that we incorporate at our site to help other centres, because ultimately it's about good patient outcomes. So thank you very much for joining me today, and I hope to see you soon. And if you do have any questions, please feel free to contact me. Thank you very much. Good night.